Good morning, everyone. Okay. Okay. I am going to introduce Meredith. She has been working as a community engagement coordinator for the CAP since 19 December of 2017. Excuse me. As for the CARE CAP, they're a group of community members that work with the CARE CAP in research at UNC. Their main focus of engagement goals are to connect HIV cure researchers with the broader community, educate the community about HIV research, and help reshape HIV cure research trials to be more representative and equitable for the community. And now I'll turn it over to Meredith so she can introduce Dr. Margolis.
Yeah, like we just said, so the CARE is a group at UNC that does HIV cure research, and the CAB is like a component of that research. We have community members that will help advise researchers. We've outlined our goals very well. So Dr. Margolis, he is the primary investigator for CARE. He'll be presenting today on HIV and COVID. Dr. Margolis, he, as well as being the primary investigator, is also professor of medicine at UNC in epidemiology and microbiology. I'll keep it short and sweet. So Dr. Margolis, if you want to take it away.
Hi, thanks for joining this morning. My background is really first and foremost a infectious disease doctor focused on HIV treatment my whole career. In the last year, like everyone else in infectious disease, we've been dealing with this newer pandemic. Today, I guess what I wanted to cover is some, sort of historical comparisons of the past with what we're dealing with now, and ways that the COVID pandemic, that the HIV pandemic, which preceded COVID, prepared us to deal with COVID to some extent, and some ways that it's new or different, focusing on really more COVID than HIV. I have some material at the end, if we have time and interest, to sort of talk about our work at the Cure Center and in CARE. The Cure Center is a UNC research group that focuses on developing HIV cure strategies. CARE is an NIH-funded collaborative group that includes UNC, as well as Duke and Emory and Oxford and several other institutions and several large pharmaceutical companies also trying to develop curative therapy for HIV. And the Community Advisory Board helps us sort of engage and talk to the community and be responsive and sort of informed by the community about what's important to them and what the messages are that we, the researchers, need to be hearing, and what the messages are that the community needs to be hearing from us. So we're, always trying to do this better than we maybe have in the past. But let me get started with the discussion about COVID-19, which is, of course, caused by the severe acute respiratory syndrome coronavirus type 2, very much like AIDS is caused by HIV. COVID was named for the year in that it was discovered and developed. And it's really amazing to think that a tiny, probably single bunch of viruses somewhere far away in a country have spread all over the entire globe in less than a year. But these sorts of things can happen, and we have to deal with them. So as you know, SARS-CoV-2 is largely spread by inhaled droplets into the respiratory tract of uninfected people. And they're may be some transmission of droplets that have landed on a surface, and then someone inoculates those droplets into their mouth or nose. But primarily, we think it's mostly transmitted by droplet spread. And so, of course, as you know, although there are many symptoms of COVID infection, the primary ones are fever, cough, and difficulty breathing. And so I go over all of these things with every group at every level, just to make sure that we're talking about the same thing. And droplet spread is important to understand sort of the physics of droplet spread. And really, the big danger is at shorter distances, less than 6 feet. Droplets can be carried longer distances, smaller ones, fewer ones, but the amount of infectious virus that can, go that far drops off very much. So the risk at greater distances drops off very much. And of course, as you all know, masks are key to protecting ourselves and helping us to protect others. This is a very nice picture from the Science magazine showing that if the infected person isn't wearing a mask, the uninfected people, they are safer wearing a mask, but the reduction of risk is much less than if the infected person is wearing the mask. The reduction of spread is very substantial. And then if both sides are wearing the mask, you have almost 100-fold reduction of the risk of infection. So it's really quite effective. There's some classical stories of this. This is a restaurant in China where the patron sitting at the table in yellow, Mr. A1, they had a several-hour meal in an enclosed space with air coming from the air conditioner on the right. And this one person infected a number of other people at his table and other tables nearby. All of the other patrons and people that worked in the restaurant, and there was an adjacent room that was also filled with people, none of those people were infected. So it's really this close contact over time exposure to particles. Another famous case now is in a hospital ward in China where a single person had COVID. That's the person in red, in the bed in the red. And all of these other patients were in beds near to him. The rest of the ward was full of people and nurses and caretakers going all around. But there was really no infections because all of the patients and all of the staff were wearing masks all of the time. So I won't go through these in detail. I hope you have seen these messages hundreds of times. The need for face covering, for distancing, for avoiding gatherings, all of these things we know very well about. So I'm going to go into some of the legacy of HIV response and HIV development of treatment and diagnosis, and how that has helped or led us to respond, to be able to respond to COVID. And this is sort of an outline, and I'll go over it piece by piece. The development of the viral load assay, sequencing of viruses, drugs that block virus entry, clinical trials advances, and vaccine strategies. So vaccines are obviously like masks. We give vaccines for two reasons: to benefit the individual and to benefit the community. It's sort of obvious. And the idea is to teach the body's immune system how to respond to the virus before the initial exposure, so that when an exposure comes, the immune response is there and prepared and ready to either prevent the virus from gaining hold or to reduce the disease caused by new infection. And the other thing that's very important to understand is that there are no live virus vaccines for COVID, for SARS-CoV-2. We are only giving pieces of the virus to teach the immune system how to make various responses, be they antibody responses or be they responses by immune cells. We're not giving the whole virus. It doesn't create an infection, and it doesn't permanently alter the body of the vaccinated person. It doesn't incorporate any material into your genes, your DNA. It doesn't permanently alter any of your cells. So what do we know about blocking COVID infection and SARS? How does this work? I didn't ask, by the way. First of all, I assume everyone can hear me. Second of all, you're seeing the slides okay? Or, okay, your nodding is very good. That's helpful. Thank you. So this is an electron microscope picture of a SARS virus, and you can see the little knobs on the outside of the virus as it's sticking to the cell. And electron microscope structures of these knobs have been made, and in just a few months after discovering the virus, and that's a picture of the spike protein. And so we understand in really great detail the structure of the spike protein and how parts of it touch a cell and allow the virus to get into cells. So the primary receptor that the SARS-CoV-2 enters cells are a receptor on human cells called the Ace2 receptor. This is a receptor that's on many different kinds of cells, but especially epithelial cells that line the respiratory tract, the nose, the lungs. And so the spike protein is able to bind to the ACE receptor, and then after several more binding events, fuse and enter the cell. Very much like HIV is able to bind the CD4 receptor on T cells, then bind a second receptor, a chemokine receptor on T cells, and then enter cells. And so the understanding of how to do this structural work and understand that entry pathway really started first with HIV over 30 years ago. And all the technology that's grown up allowed us to very rapidly understand this entry response of the new virus that we were confronted with. And so one of the primary immune responses to prevent this kind of binding and entry event is the presence of antibodies. And antibodies are Y-shaped molecules. You can see them there in green and purple. And the purple parts recognize the virus spike protein and block critical parts of the spike protein, preventing it from engaging with cells. And the goal then is, one of the major goals in therapies is either to give people antibodies like this as therapy, or to make small molecules that act like antibodies. None of the small molecule work has yet been successful. Or to vaccinate people, to teach their bodies to make effective antibodies like this so that they carry them around with them for sufficient time to be protected. So one of the new technologies that is being used in the Moderna and Pfizer vaccine is called RNA vaccines, RNA vaccine technology. And this was actually first discovered sort of by accident in HIV vaccine research more than 15 years ago. We generally think of RNA as a very fragile, short-lived molecule. So RNA is the messenger molecule that's made from your DNA, from genes. RNA is produced by reading off the DNA template to make a matching piece of RNA. And then RNA goes to the protein manufacturing parts of the cells, the ribosomes, and the ribosomes read the RNA and make the protein they're instructed to do so by the RNA. So your cells, of course, have all sorts of normal cellular RNA that make pieces of the cell, but the virus is an RNA, the virus RNA instructs the host cell that it's infected to make pieces of viral protein. And so RNA is generally pretty fragile and doesn't last for very long. And so it has to be sort of continuously produced to make proteins. But to our surprise in HIV research, it was discovered that if you just injected RNA or introduced RNA into cells, it would last sort of longer than we thought, and it did a pretty good job of making protein. And so instead of giving cells protein as a vaccination, so to make, for instance, influenza or HIV antibodies, you didn't have to inject protein into cells to have the antibody response made. We could inject RNA into cells, and the RNA would make the protein that we would like to see an immune response again. The RNA would go into the cells, be made into the protein. The protein would be presented on the surface of the cell because that's where the viral envelope spike protein naturally goes to assemble particles and be presented. And the immune system would then see the viral protein on the outside of a human cell and make a response to that protein. So what happens with the Moderna or the Pfizer vaccine is that you get a shot in your arm, and the RNA that's in the vaccine, the viral RNA, is directly injected into muscle cells. The muscle cells then make this virus protein for a few days. And the protein hangs around for a few weeks, and it's displayed on the outside of the cells, and your immune system sees it and can then develop antibodies to that foreign protein, which it recognizes is not supposed to be there. But the muscle cells are not permanently changed. The RNA does eventually go away in the muscle cells. The protein eventually goes away from the muscle cells. And so it's simply a very efficient way to be able to generate immune response to whatever protein you like, because RNA is relatively easy to be manufactured, and you can manufacture it in whatever sequence is designed or desired. And so we can actually make, if the coronavirus mutates over time and the kinds of coronaviruses that are out there change, we can simply change the RNA sequence and we have a new vaccine that should work pretty well. So like many vaccines, the RNA vaccines have these typical kinds of side effects that you sometimes get from an immune response. It's very variable between people. I got my COVID vaccine in January because I'm a first line health provider kind of person. And I had a sore arm for the first shot. And the second shot, I didn't have any response at all. My wife just got vaccinated, her second vaccine this week. She had a sore arm the first time. And the second time she had a more sore arm. And then in the middle of the day yesterday, all of a sudden she felt terrible, felt like she was just exhausted and felt warm, and she lay in bed for an hour and it was all gone. So a very variable, and she's fine. So very variable response, and sometimes some modest symptoms, but they seem to mostly go away. Like many drugs and vaccines, infrequently people have more severe allergic reactions. Those are usually relatively immediate after the vaccine. And those can generally be managed by medical care for those sorts of reactions. There is another thing to think about that's just sort of coming up now. We used to have to deal with this, or we did have been dealing with this in the HIV world when we were trying to make, or still are trying to make, preventive HIV vaccines. Someone would enter an HIV vaccine trial, and they would get an HIV vaccine, and they would make antibodies against HIV. If they went to some other medical place for some reason and got an HIV test, they would sometimes test HIV positive because they now have HIV antibodies, but they were not actually HIV infected because they had only received a vaccine. So that was a challenge in the development and testing of HIV vaccines. Similarly, this may be a practical thing to think about and to be informed about, because if you've had a COVID vaccine and 6 months later you get a fever and you go to an emergency room, you would want to be sure that whoever was taking care of you knew that you had the COVID vaccine in the past, because there are tests that people use in hospital settings now that detect COVID antibodies, not COVID virus. And so would want to be clear that, just because you have COVID antibodies after having a vaccine doesn't necessarily mean you're infectious and doesn't necessarily mean that you have COVID. It has to be thought about because rarely and frequently people can get COVID after having the vaccine. That's happened a few times. So it's just another one of these points of how important it is to sort of understand your medical care and to be involved in it. I also thought that I would just throw this piece of information in because this is a group that is interested in HIV, and there's a lot of questions and concern about the overlap and intersection of the two viruses and what happens to people that are HIV positive that might come into contact with COVID. And these are two sort of position statements, one on the green side from the CDC and one from the NIH. And basically, it does not appear that someone who has HIV infection but is under care and being treated for it, there's not really a noticeable difference in either the risk to them for getting COVID in the first place, the risk to them of getting sick from COVID if they're exposed to it, or the effectiveness of any COVID vaccines should they be vaccinated to someone that is HIV uninfected. Certainly, if you're HIV infected and you're not treated and you have some immune deficiency because of the lack of HIV treatment, there may be increased risks of illness from getting COVID. That would be a bad thing. The people that are most at risk from COVID infection are people with other sorts of immunosuppression, often from diseases like cancer or from organ transplants. And then other people that have comorbidities like diabetes, obesity, hypertension. Those people do less well if they unfortunately get COVID infection. So that was really all that I needed to cover. This is our, sort of ad for our cure research at UNC. And I wanted to, I guess, just open the floor to folks to see if you're interested in sort of hearing more about the cure research programs that we have going on right now and what is coming down the road, or if you wanted to talk about any questions about COVID or COVID and HIV. And if you'd like to talk, please remember to unmute yourself.
Hi, Dr. Margolis.
Hey, Angie.
I had called you before I even considered getting the shot. Because
Did
I had
you call me from the line waiting for your shot?
I did. Because I was nervous because I'm positive and I didn't know how it would affect me having the shot. Because every time I go to my doctor they always see what medicine coincides with me to be able to take, being that I'm positive. So I didn't have anyone to call but you. And I know that you're working on both fields of the cure and the COVID. So yes, and I thank you for this screen that you're showing. I've been taking pictures, so now I really, really have it's registered deep in my mind. But my question is, like, I get my second shot Monday. You may get another call, and I'm listening at what you were saying. Different people have different side effects. So if someone that is positive, how does that? But then again, every person is different, right?
Yeah, it would have much more to do with just your differences rather than the fact that you're, living with HIV, I think. It's really hard to generalize. I think it wouldn't be a bad idea to sort of be able to set time aside the day after you get your vaccine, just in case you don't feel great. And but most likely you should be fine. If you feel crummy, take a little Tylenol or something like that. But
yeah, because I'm listening at everyone, everyone's from their second shots, but everybody has different go through different things in their bodies and whatever. So I'm gonna write down. I'm like, what should I look for? What should I look after? I'm nervous.
I would just, it is what it is. Don't worry about it too much. You'll be able to deal with it, I'm sure. And if if you're really worried, call your doctor or go to a clinic. But generally, problems are mild, treated by home remedies, those sorts of things.
Okay, thank you.
You can tell yourself that if you get a fever or some sort of reaction, it's a sign that your immune system is working. So that's a good thing.
Great to know. And not that something is wrong from the fever. Thank you again.
Dr. Margolis.
Yeah.
So I have a scenario. So if person A and B have a mask and they're around person C and they're in close contact, not 6 feet apart. Person C coughs or sneezes. What happens to the mask that A and B are wearing? Are they at risk of when they take the mask off, catching some of the virus from the person that sneezed without really recognizing that this has happened?
Yes, this is a concern, and I think we should all try to be careful without driving ourselves crazy. Certainly, the outside of the mask has on it whatever is there, and so this is why it's a good idea to replace your mask every couple of days if it's a paper mask, or wash it every couple of days if it's a cloth mask. And it's another reason why it's a good idea to wash your hands frequently. If you're handling your mask and then you take off your mask to go eating, you might be taking particles from the outside of the mask and then, eating them, which would not be a good thing. So you should wash your hands. So that sort of a scenario is something that you just need to take care for by washing your mask occasionally and washing your hands, when you can, often.
Thank you.
Good afternoon, Dr. Margolis. Thank you for the great presentation. I have
Hi,
a
Thomas.
question. I got my vaccine on the 19th of this month, and I got the J&J, and I did not have, I've been doing great. No side effects, no fever, no sore arm. Can you explain why? I'm not complaining, but I'm just saying.
Can't tell you.
Right.
That's probably the majority of the people have no reaction other than maybe a sore arm for a day or something.
Okay.
And that's
I mean-
known. That's
Do you get the flu shot every year?
I do.
What happens when you get the flu shot?
I'm fine. I get it at the clinic where I go. I
Yeah.
get all my shots. I stay up to date with everything. So yeah.
But you don't have side effects from a flu shot.
No, sir, I don't.
Maybe you're just a tough guy.
I just thought to ask because I hear so many, certain people getting different side effects and everything. So I just thought to ask.
Yeah, I think, we always hear the bad news. I think most people who get these vaccines have really very few events.
Right. Okay. Thank you for explaining.
I got both my shots. I've never had a reaction, never even had a sore arm from mine.
Yeah.
So I'm real grateful for that.
Dr. Margolis, can you explain what the difference is between Pfizer, Moderna, and Johnson & Johnson? Why did the first two come out and you have to get two vaccines versus Johnson & Johnson where you're only taking one? So is one of the two that you get twice and versus the one that you only get one, are they more effective or vice versa?
Well, that's a good question. And there's actually several questions there. I think the first part of the question was why did Pfizer and then Moderna, why did they get licensed first? Those are the two RNA vaccines, and that's an illustration of the RNA technology is easier to engineer and make and produce more rapidly. And so they got through the process of making, testing, and licensing and producing vaccine faster than the other makers. The downside of the RNA vaccine technology is that the RNA is, more fragile. And so these are the vaccines that have to be kept very cold and can't be left in the refrigerator for weeks and weeks. So they have to be thawed and used, in a rather prompt way. The J&J vaccine is a more typical vaccine. It doesn't use RNA, it uses protein. So it is jabbing viral protein into your cells directly. And the protein is then being displayed to the immune system to make an immune response. It's also combined with other proteins called adjuvants. These are sort of irritating proteins that get the immune system excited, and the immune system comes to see the irritation caused by the irritating proteins and gets a better look at the viral proteins and makes a better response. So if you give the J&J vaccine proteins without the adjuvant, you get very little response. If you give it with the adjuvant, you get a bigger, more effective response to the viral proteins. And the way it works out, and this is just studied over time, as these vaccines are developed, the J&J response seems to go up to an adequate level and last for a very long time with only a single dose, whereas the response to the RNA vaccines so far, the Pfizer and Moderna, you get a decent response to one shot, but it's felt to really get a bigger response that lasts so long, you need a booster. There may be RNA vaccines in the future that get developed that are potent enough to only be given at one shot. We also don't really know when for sure, when you're going to need your third booster, second or third booster in 6 months, well, not 6 months, in a year or 2 years or 3 years, right? We get a flu shot every year. We get a diphtheria, we get a tetanus shot every couple of years. We get a pneumonia shot every 5 or 10 years. We get a zoster shot maybe just once. So it depends on the pathogen, what the immune response is, and we need to sort of determine those things by studies over time. So probably everybody will need a second COVID vaccines someday, but we just don't know what that, when that is going to be quite yet.
Thank you.
Another question. So I have read that the fetal cell lines were used to make the Jnj vaccines. Why was that, or is that true?
Oh, I've lost track of who used what. These things are, products are generally developed with technology and tools that have been in the laboratory for decades and have a very long safety record. So I think some of the cell lines, cell lines that we work with in the lab, when we call them lines, that means they essentially live forever. They can divide and divide and divide and divide and divide, and they never die. Those are really cancer cells, because normal cells don't live forever. They can't divide hundreds and thousands of times. Mm-hmm. So cell line was a normal cell once upon a time, developed a mutation, essentially became a cancer-like cell. And so it can live in the lab forever, and we can use it to do research. And some of these cell lines have been studied for very long times and shown to be safe, and we can use them to test or develop vaccines, or make proteins that we then use. We use the cells as biological factories to make proteins that we then put in the vaccines. And so the original cell that made some of the cell lines for some of these products may have come from, I'm not sure where, potentially, for instance, fetal tissue, the remnants of conception, or the remnants after an abortion procedure.
Yeah.
And they may have come from 20, 30, 40 years ago. You probably know the is it Helen Lane? What's the HeLa cell?
Henrietta, is that
Henrietta Lacks, that's it.
Yeah.
Probably heard the Henrietta Lacks story. This
Right.
is a woman who had, in the 1940s, I think, had a cervical cancer, had a biopsy. Some of the biopsy tissue was, somebody in some lab used it, and they used that cancerous tissue to develop this cell line, which they then called HeLa, H-E, capital H-E, capital L-A. The HeLa cell line has been used in hundreds of thousands of research projects across the world. It's one of the most useful cell lines for various research reasons, scientific reasons. But it, came from this person long, long ago.
Right. Thank you. I had just read about that. The article was on the 4th of April, and just wanted to get some more understanding about it. But thank you. I'm at March. It's not even April yet.
Lee, did you just join? I don't remember seeing your name earlier.
I did, yeah. Sorry to be a little late. I had something else this morning.
No problem. Nice to see your name. There you are. Well, anyone else? I see Michael joined also. I know some of you.
Did anyone else have any other questions?
Awesome. Well, thank y'all so much for joining us this morning and for that wealth of information. I think it's so important for us to continue to share this information wide and far for our community. As I mentioned, this was recorded, so we'll upload it onto our YouTube page. So if anybody was not able to join this morning, they can watch it again and gather this information. I did want to make an announcement that next week we have not created a registration page or a graphic yet, but our friends at the Latino Commission on AIDS will be joining us to give a presentation around some immigration policy and some updates around that, both here in North Carolina and some national information. So keep a lookout for that. Hopefully we'll have that registration linked live and we can send that out as a follow-up to folks who registered for this today. But hope everyone has a wonderful, great rest of the day.
Matt,
Yes.
one more announcement. We're now taking registration for HIV Speaks on Jones Street on May 4th.
Yes, thanks for grabbing that, Rita. Totally forgot to mention that. But yeah, registration opened yesterday for HIV Speaks on Jones Street. Would love for y'all to join us. I will drop the link in the chat right now for anybody who's not able to or did not get that email yesterday. So that's our annual advocacy day. It'll be all virtual. Have a chance to talk to our representatives about important HIV advocacy and policy issues. So with that, I'm going to stop the recording